Um, Today's lecture is about postnatal growth. In the last lecture, we talked about embryology and prenatal growth. Today's lecture, we're going to talk in the first part of the postnatal lecture, and the next week we're going to continue discussing this subject. Today mainly will be introducing the terminology that we are using in the growth, so that in the next lecture, when we start talking about the growth and the theories of the growth and the maxilla and the mandible and the face growing, we can understand what do we mean by all of these terminologies. So we will start by talking about growth versus development. When we say growth, that means there is an increase in the size or number of the organ, and that's mainly an anatomical phenomena. While when we say development, that is an increase in the complexity of the organ, and that's mainly a physiological and behavioral phenomena rather than an anatomical one. Now, postnatal growth, if we want to divide it into periods, we can go from infancy, which basically the first year of life, then childhood, which goes from the first year to the 15th year of life, then adolescence, which basically depends if it's male or females, it goes from 14 or 13 up to the 20 years of age. So this is usually how we divide the postnatal growth, and more than 20, that would be an adult patient. Now, when we discuss growth, we need to understand what do we mean by something called growth pattern. And growth pattern is basically the physical arrangement of the body at any one time in the space. So the way the organ or the face or the body is organized and divided is called the pattern of the growth. So to understand it, we can look at this paragraph here. You can see that during the 2 months of intrauterine life, the head is taking more than 50 or almost 50% of the total body, while the legs are taking less than maybe a quarter of the body. Now, after birth, that the head is reduced to be only 1/3 of the body, while the rest of it is for the upper limbs and the lower limbs. And here you can see that the lower limbs are taking mostly half of the size of the body. Now, this is the way how they are organized, how the way the growth is happening in this particular description. That's called the growth pattern. All right. And as we go toward the adult life, we can see that the head mainly 12% or even less than that of the total body, while the limbs and the lower limb particularly are making almost half of the body length. So these changes from here to here, we call it growth pattern, how the pattern of the growth is happening. For that reason, when we describe the growth pattern in the human being, it's called cephalocaudal gradient of growth, which means that there is an axis of increase in the growth extended from the head toward the feet. So as you go from the head toward the feet, the growth will be increasing. So as you can see, as we discussed here, now this is during the intrauterine life, and you can see that the growth is happening more as you go downward. So here the lower limbs growing more than the upper limbs. The upper limbs are growing more than the head, and we call this cephalocaudal gradient of the growth. And if we apply this cephalocaudal gradient of the growth to the skull as well, we can see that at birth, most of the skull is formed by the neurocranium, and the face is having less than 1/3 of the skull. But as we growing, and because we're doing into the cephalocaudal pattern of the growth, this part will grow more than the cranium. And if we go closer as well to the maxilla and mandible, we know that the mandible, as we go in life, will grow more than the maxilla. So that's what we call it, cephalocaudal pattern of growth. So during development and during growth, we can expect that the mandible will grow more than the maxilla will grow more than the cranial vault or the cranial base. Now, this is a photograph showing you the difference between the skull of an adult and the skull of a child or an infant. And by the first look, you can tell that the huge differences between the skull of the adult and the skull of an infant. So the first one is that the skull of the adult, the face is much smaller or taking much less space compared to the face of the adult. So most of the skull during the first infancy will be mainly formed from the cranial vault, not by the face. The face will be smaller. And the cause of that, because the mandible, the maxilla, the nasal cavity are really small at that point of stage. And later on they will catch up and will grow more. So mainly during the infancy, the orbit and the cranial vault will take most of the skull. Later during the growth, they will speed up the maxilla, the mandible, and they will take slightly from the side of the orbit and the cranial vault, and they will have the balanced skull of an adult. And also, most of the skull, the bones of the skull are smaller in infant compared to an adult, which makes sense at that point of age. And in the skull of the infant, we have something we call it fontanelles, which basically these are sutural membranes that is presented between the bones. So the importance of these sutures or the fontanelles, that it will allow a little bit of flexibility of the skull during birth when the child go out from the birth canal, so that the skull can be slightly squeezed because the child will be born passing through the birth canal. These fontanelles will all close by the age of 18 months. However, that's why when you have a kid and a baby, they say, be careful when you're playing with him because his bones are so soft. That's what they mean by that. So they will stay like this until the age of 18 months, which is a year and a half. And also, in the infant, we have additional 2 more sutures compared to the adult one. The first one is the symphysial sutures, which is presented in the mandible between the right and the left mandible, which will close by the age of 2 years. And we have the metopic suture, which is present between the 2 frontal bone, this one here, that will close as well by the age of 7 years. So these are slightly the differences between the skull of an adult and the skull of an infant. And you remember we said about the growth, how the growth of the adult mainly happen in the cephalocaudal direction. That's to summarize what we just said. And that's mainly the growth will be of the face compared to will be more of the face, maxilla and mandible compared to the eyes and the cranial vault. So these are graphs that will help us to understand this more. In the top graph here, that's measuring the head circumferences of a girl from birth until the age of 19. So each year we're just recording the circumference of the head. And as you can see that each year during the first 3 years, there will be huge increase in the head circumferences. And then it will stay increase, but the rhythm of the increase is much less than in the first 3 years. And then at the age of 17, there will be no increase in the head dimension. That will tell us that during the first 3 years, most of the growth of the head will happen during this time, which is the first 3 years. Then we will be having growth, but this growth is there, but it's minimal compared to the growth that happened during the first 3 years. And this one here is called the velocity curve. And we're going to hear this word a lot, which basically you don't record the increase in the dimension, you just record the changes in the head circumference. For example, I measured the head dimension and it was 30 centimeter. Now next year I measured it and it was 40. Now the difference between them is 10 centimeter. That's the change, the amount of the change. So here in the graph you plot 10. So that means that during the first year, there will be a huge amount of growth happening. Now the next year, you measure that skull and we said it was 40, and then you measure it again, it was 5. So there is an increase of 5 centimeter during 1 year. So then you go and you plot 5. So that tells you the rate of the changes, how much active is the growth. And you can see that the first year is the best, it's the most of the increase in the head dimension, and it keeps like this until the age of 3, and then the amount of the changes is minimal. There is a growth, but the amount of the changes is minimal. So that confirms that most of the growth of the skull happening during the first 3 years of life. And then if you split them, the growth of the cranium alone and the growth of the face alone, as you can see here, the percent of increase. And you can see that the growth of the cranium is much less than the growth of the face. The growth of the face is more as we go in life. And that again goes with what we said about the cephalocaudal growth pattern. And also it goes with the fact that during the growth of the skull, we will have less space occupied by the face during the first years of life. Then later the face will catch up and it will have the proportion that we have it in the adult one. Now, in this lecture, we're going to jump between like different bits and pieces so you understand the difference mechanism later on in that so this lecture mainly is a preparation for the next lecture. So here we're going to jump from different topics to understand the different terminologies in growth. So what are the mechanisms of the craniofacial growth? We have two mechanisms in which the growth can happen in the cranium. The first one, we call it the relocation one. So basically what's going to happen, we're going to have a bone resorption at one side and we're going to have a bone deposition on one side. If this bone resorption is equal to this bone deposition, what we're going to have is that this structure will relocate from this area to this area. And this relocation will happen without any increase in the size of this bone. However, if you have more bone deposition than bone resorption, that will be associated with increase in the size, and they will relocate as well. The second mechanism is, we call it growth displacement, and that's basically it's independent and it's can happen as long as relocation at the same time. And usually this one is due to an external forces that is applied to the structure. Usually that happen from brain muscles that will exert a force on the bone that will stimulate it to grow in that direction. We have a terminology called the growth variability, which means that not everybody is alike when it comes to growing, and that we need to address and to know about the racial and ethnic differences when it's come to growth and the differences between boys and girls. How to understand that? So first, this is a very well-known curve. It's called the normal distribution curve or the Bell distribution curve. When we're doing growth, we say, for example, let's say that growth spurt will happen at the age of 12. So what does that mean in a statistical point? 12 is the mean value, which basically means that 50% of the sample that we examine, they have the growth spurt at the age of 12. So it doesn't mean that all of them are the same. It doesn't mean that everybody should have the growth spurt at the age of 12. And here it comes the variability. Now, then we get, for example, 12 plus minus 1. So that will give us a range from 11 till 13. We call this the plus minus is a standard deviation. So the mean value minus 1 standard deviation plus 1 standard deviation, which is this area here, which is, if we take the example of growth spurt, will be from 11 to 13. It means that 68.2% of the sample that we have having the growth within this area here. And that's why we consider everything within the first standard deviation as a normal one. And that's what we do when we do the lateral cuff tracing, and you do, for example, an SNA value, and you say the SNA is normal 2081 plus minus 3. So the whole range is considered normal because that is within the normal population, which is 68% of the population is within this one. When you go outside the first standard deviation, that's you start to be not within kind of normal distribution, because now you are representing the rest of the 68, which is almost 32%. So you are part of the 32% of the population. If you have more than standard deviation, if you have more than 2 standard deviations, so you are outside the 95. So are you within 55% of the population only, and that means that you are the extreme one. But what we need to understand here is about the variability. The growth is variable, and it's different from one person to the other. It's different from between races as well. So, for example, if you go to the Asian Japanese, they are shorter compared than Eastern European, that they are much taller. So here again, that's variability of the growth that's happening. And here it comes, how we gonna time growth? So if you say that the growth is variable, then how I'm gonna time this growth? When I'm gonna say the patient will get taller? When I'm gonna say that the patient's gonna have the growth spurt? The first way to do it is to use what we call it the chronological age, which basically the amount of time since birth. Like this patient is 15 years old, 12 years old. But this one is not accurate because simply we just mentioned about the variability of the growth. And because of the variability of the growth, you can't use the chronological age. Again, I keep giving examples and different examples. Canine eruption. We know that the canine should erupt by the age of 12 to 13. Now the question is that a must? Well, when you say 12 to 13, that's a chronological age. But the patient, the canine, might erupt at the age of 11 because we have a variability. And here it's come what we call it the biological age, which basically it measures the age according to the developmental marker or developmental stage. Like for example, dental age, sexual age, skeletal age, morphological age. Like take the dental age for example. We look at this at the patient and examine him. Okay, so we see if the canine has not erupted yet, the premolars has not erupted yet, and only he has the lower 4 incisors, upper 4 incisors erupted with the first permanent molar. We say, okay, then he is 8 to 9 years of a dental age. And maybe the kid is 10 or 11 chronological age, but we measure the maturity of the biological age of this patient. And this is kind of more accurate compared to the chronological age. Now, how the organ grow? There is a mechanism, or there is a nature, we call it, of the growth. It happens at the 3 levels. The first one, we call it hyperplasia, in which there will be an increase in the number of the cells. And then we have something we call it hypertrophy, which basically increase in the size of the individual cells. And we have something we call it the secretion of the extracellular material. So here basically the cell size, the cell number is not affected. The cells are producing material extracellular, all right, and that will increase the size of the organ, but not the size of the cells themselves. And this one is mostly important when it comes to the skeletal one. As you remember when you said about the growth of the bone, we said that osteoblast first deposit osteoid, and this osteoid is considered as an extracellular material. Then this osteoid will be calcified to be a bone. Now the secretion of the extracellular material can be divided into 2 types. The interstitial growth, where the growth occurs at all the points of the tissue. There's no certain area. Everywhere in the organ there will be growth. And that's mainly happen with the soft tissue and the uncalcified cartilage within the skeletal system. Or we have direct or surface deposition, where for example we have a bone deposition. It's like it happens on the surfaces. It's just having surface by surface by surface, layer by layer by layer. All right, that will be mineralized. So we call this direct or surface deposition, and that happen mainly bone, teeth, and the calcified hard tissue. So soft tissue mainly interstitial growth, while hard tissue usually hard or soft tissue, hard or surface deposition type of growth. Again, there's many concepts happening here. So we have certain definitions as well about growth. Something we call it center of growth, which basically the location where independent growth happen. So if you take this organ, for example, if I say condyle is a growth center. So if you take the condyle and you place it in a media, it will grow by itself without any influence from anywhere else. While site of growth, basically the location where growth happen. But then that growth is happening due to a response from somewhere else, or just growth happening. So if you take this place to somewhere else, they might not be growth. So basically the center of growth is the site of growth as well, but it has the internal ability to grow by itself. That's the difference between the center of growth and the site of growth. While the site of growth can't be a center of growth, it's just a place where the growth happening. Now we have primary translation of displacement, which means active movement of the structure itself. Right? The other option is secondary translation of displacement, which is an active or passive movement of the structure. For example, the cranium, the brain is growing, it's pushing the skull forward, and the frontal bone and the nasomaxillary complex. So the maxilla will be displaced as a response to the growth of the cranium. We call this secondary translation or displacement. So now all the studies, all the growth that we're discussing, most of it coming from growth studies. So there's a huge growth studies that's done trying to understand growth. So if you define it, it's basically a database of one or more measurement of growth, such as height, weight of heads or head circumferences, that is indexed by sex and age for a given population. So basically, it's going to tell you measure the height of this population. Say, okay, by the age of 5, this population have an average height of 100 centimeter. By the age of 18, they will increase 10 centimeter per year, and they will get into 180. And again, this is all averages. So that's all the aims of the growth studies. When you say growth studies, we have different types of the growth studies. The first one is called the longitudinal studies. And in these studies, it's involving measuring these measures on the same individual over a number of years. So you get a kid, for example, who is a year old, and you measure his weight, his height. And then a year later, you have the same kid, and you measure the same measurement. And you keep repeating this until he's 18. Well, that's fantastic, but these studies are difficult to conduct. The results are amazing, but it takes a long time to do, and it needs commitment from the patients, because you can't guarantee that this patient will stay in the same area and not relocating after a year or 2 or even 3. And plus, to conduct an experiment like this, it's really expensive to do it. So the data that we get is important from longitudinal. It's essential to know the growth velocity curve and to identify variation in the growth pattern. But these studies are extremely difficult to be done, and there is a limited number of these type of studies. It's very important that we have a limited number of these studies. Then we get the cross-sectional studies, which basically it collects the data from different children at the same time. So what does that mean? For example, I want to know now the height of the kids in that area from the age of 1 till the age of 18. So I will do and get a group of kids who are 1 to 2 years old, and then another group who are 2 to 3, and then another group that are 4 and 5, and so on until I'm 18. So I have multiple groups with different ages that I took the height for them at the same time or at one time point. So basically, that's why it's called a cross-sectional study. Okay, so you're getting the numbers from different population at one time, but they have different ages. So as you can see, that this one is easier to do. It will take a shorter period of time to conduct, and it's cheaper to be done compared to the longitudinal study. However, this one can't give you number for the individuals. It gives you to the population wise. You say, okay, the growth, the height of the individuals and the populations are like this. And as I said, it's done in a short period of time. Now, usually when you use a cross-sectional study, you do something at the population level, and in order to have national standards, usually they use this kind of studies. But then, according to the UK guideline, to have a standard or like national standards, it has to have a sample of 1,000 boys and 1,000 girls in each group. Then we have the mixed longitudinal study. So basically, it's a mixture between the longitudinal study and the cross-sectional one, in which basically you get the kid and you have different groups, and then you follow them for 3 to 4 years instead of following them for 18 years. For example, you get the kids group between the age of year and 4, then another group between the age of 4 till 8, then another group 8 to 12, then 12 to 15, and then you follow them until the age until 3 to 4 years. So you have, again, you can get data longitudinal, but not taking as much time as you're doing the purely longitudinal study. Now, as we can say that the most common form of the growth studies that are published are cross-sectional study, but the one we're going to discuss today are the longitudinal one, because that's why they are limited number, because they are really hard to do. So we're going to discuss today the longitudinal studies, not the cross-sectional studies, but the published in the papers that the most common of these ones are cross-sectional studies. And as we mentioned, it's easier to do the cross-sectional study, and it's quicker, while the longitudinal one is more expensive and needs more time to do. In the longitudinal study, we can get the variation on the individual basis, while on the cross-sectional study, we do it as a mean annual growth for the whole population. Now you just need to know that most of the studies that we have, the longitudinal study that we have in the 20th century, are based on the cephalometric radiograph reading. These are the most common measurements for, as I'm talking now, according to the from orthodontic point of view or the craniofacial growth point of view. Most of it use cephalometric radiograph. Some study have blaster models as well. And an important point that most of these studies are even predominantly happen in Europe and Northern America. So basically, these growth studies looked at the Caucasian of the Northern European ethnicity, which means that as a population in the Middle East, that will not be very accurate to apply on our population. So the first study is the Mexican growth study, and that took place between the 1953 and continued until the 1959. And the original sample was 83 individuals, 47 male and 36 females, from the age of 6 to the age of 16, and they followed them. And they came up with two major atlases on the cephalometric standard and the dental cast measurement, and then they published it. And if you look carefully at this type of study, this one is not really longitudinal. Maybe you can consider it as a mixed type longitudinal with cross-sectional, because they did not follow them for 18 years. The second study is the Bolton study, which is done from the 1929 until 1959, which basically 30 years, and it's done in Cleveland, Ohio. And after that, they published this one into Atlas, and it's called the Bolton Standard of Dentofacial Development and Growth, and that was published by Broadbent in 1975. They looked at the data and they published it. When they looked carefully at what they published, and they looked carefully at the atlas, and that will be very important when we discuss next lecture, that there will be a small consistent increase in the magnitude of the facial dimension, both females and males. Lakin, there was no evidence of growth spurt. That's what they said in the Bolton study. And what they said, at each individual is variable entity and will show changes in the growth magnitude at varying time in his or her developmental growth. Which means that each individual, they are variable in the timing of the growth and the magnitude in the growth. So for example, one child might grow a lot at the age of 10 years, while the other child might grow a lot at the age of 15. So they are variable when it comes to that. And what they concluded in the Bolton study, that trying to average the results of these studies kind of get you lose the differences or the individual variation that we are having, and they did not consider, or they did not recommend, that we need to average these values that we are using out of the growth studies. Like for example, when you're using the SNA and you say the normal SNA is 81 plus minus 3, that's what they were talking about. The third one is the one done in Burlington in Ontario. The fourth one is done in the UK. And that one is done in King's College London, and it began in 1952. And in this study, what they did is, when they start doing the study, they start looking at the sample from the patients that they are having. So they look back into what record do they have for these patients. And they, for example, they say, okay, the inclusion criteria for this sample, that each kid have a study model and lateral cuff every year. So they went to the hospital and they looked back and they saw the cases in which they have a lateral cuff and study models for the last, according to the criteria that they have, and they included. So this study kind of considered as a longitudinal study, although they did not start the study and they followed the patient for a long time. So this one started with 528 subjects of Caucasian origin, then they added 208 siblings. So these are the total of 736 subjects. And then, as we said, they only have the records enough from 121 subjects. They say, okay, we need this sets of record to accept this patient in the study. And they said that at least 10 acceptable annual record extended at least for 15 years for girls and 17 years for boys. That's the inclusion criteria. So they need 10 records, 10 acceptable annual record for at least 15 years for girls and at least 17 years for boys. So they go for 15 years because the nature of the hospital there, it's a public hospital, they take records regularly for their patients. So they went there and they checked these records until they come up with 121 patient. Now, the criteria for these patients that they should not have any gross or congenital abnormality. However, they have class 1, class 2, class 3 malocclusion. They did not consider that they have to be a normal occlusion, and they should be examined at the age of 6 months. That's the start, and then annually after that. As we said, they need to have an acceptable 10 measurement per year. So the records were almost completely between the age of 5 to 17 years, and for that reason, this study can be considered as a longitudinal study. The records that are used in the London study were plaster models and lateral cephalogram. So what is the problem with the growth studies? Are these growth studies accurate? Well, to start with, according to our population, this one is done on the Caucasian, so it doesn't work with Middle Eastern population to start with. The other one is the difference in something we call it tempo of growth, which basically is the variation in the timing and the magnitude of growth. We call that tempo of growth. We mentioned before that the growth is variable between different individuals. So different individuals grow with different timing, with different magnitude. For that reason, that's a different in the tempo of the growth. So if then you ignore this fact and you looked at the results of the growth studies, the results will be biased and insufficient. How is that? Look at this paragraph on the right side. This is basically for 5 children, in which this is the stature velocity curve, which is how much the growth will increase per year, and this is the age of the patient. And as you can see, that the 5 patients has different growth peak. One of them at the age of 9, the other one is at the age of 10 and 11 and 12 and 13. This is only for 5 kids. Then we look at the number that we got as an average value for them. You can see that the peak of the growth is at age of 11. And if it's less, and it is really less what we get on each individual level. So the problem with the studying the average value, that you ignore the individual variation that we're having. And also you don't get the correct timing. So if I'm gonna go, let's name this guy Ahmed, and then Ahmed main growth spurt happened at the age of 10. Well, if you're gonna follow this graph and you say, okay, the main growth spurt will happen at 11 to 12. So when you're gonna treat him and you were looking to the chronological age, by that time he passed already his growth spurt. And that's a huge problem with using growth charts and growth studies. So from these growth studies, they came up with a lot of charts. This data is plotted as charts that even though we know that they have a lot of problems, this is the best that we have. So we kind of have them as a guidance for us in the treatment. The first graph is called the height distance graph, which basically measure the height every year and the increase in the height and plot it against the years. So as much as you increase in the height, you record that. And as you can see, that the height of the patient usually, or the child, increased 3-folds by the age of 18. So that will tell you how much incremental increase. While we have here what we call it the height velocity curve, which basically tells you the difference in the height each year. So when the difference is high, that will tell you the rate of the growth. And that will tell you when we have a growth spurt. So as you can see here, the rate, I'm not saying that the growth is not increasing. No, the rate of the growth is not increasing until we have the juvenile growth spurt at the age of 7 to 9, there will be an increase. And then the main one, which happened at the adolescent stage, which is the growth spurt, which happens between the age of 13 to 14 in males and 11 to 13 in females. All right, so that's again a chronological age which is not that accurate. However, what most of the studies they found that the growth spurt in the male will happen at later age with a greater period of time, which give them more space to grow, and they will grow more than the females. The last curve that we're going to discuss today is called the Scammon's curve. So it's not only that different persons grow differently, it's also that different organs grow in a different rhythm. So start with the brain, for example. The brain will have the growth spurt. The main growth will happen in the first 3 to 4 years. And the peak will be reached by the age of 7 to 8. After that, the brain will not grow anymore. There will not be an increase in the size of the brain. While the limbs and the general growth of the body will have the sigmoidal kind of shape of the growth. That will have the growth spurt that happening at the age of 12 to 14, as we said. Now, maxilla follow the cranial growth, while the mandible follow the general growth. The reproductive organ, as you can see, closer to the puberty, they will have a huge amount of growth. The lymphoid tissue, they have this kind of growth depending on the immunity of the patient. But the one we are concerned is the neural one, which the maxilla follow. This is the general one, which the mandible will follow. That summarizes what we said. And then we have the growth standard and the growth curves. So what are these? These are basically developed to determine the physical growth of the child, if it's within normal or not, according to the sex and the age and the population class that he's living to. Let's see how that works. So basically you identify the patient age and then see, okay, where is this child on this graph? So you have this one here, it's called the 50 percentile. So here is the year of the patient, here is the height, while here is the weight of the patient. So if the patient is 8, it means that 50 percentile, which means 50% of the population, they have a weight of 25. So if he was here, which basically on the 75 percentile, with the weight of 30 kilogram, which means that he is, his weight is higher than 75% of the population. While if his weight is here, that will he was saying, for example, that he is heavier than 95% of the population, it's become abnormal and he might have obesity. While if it's here, we will have, for example, that he has a malnourishment. What we are trying to say, it depends on the percentile. So if the kid is in the 50 percentile, it means that his weight is the same as 50% of the population. If it is 75, it means that he is heavier than 75 of the population, and that's 25 of the population is heavier than him. That's what we mean by this percentile curve. Now this is called UK90 growth curve, and these data are driven from a cross-sectional study collected between the age of between the year 1978 and 1992. That will be it for today's lecture. We will continue the rest on the second lecture. Thank you.